Hello everyone and welcome to our webinar. My name is Russ Sabella. I'm president of the Florida School Counselor Association, and I am honored to have today as our presenter Dr. Stephanie Carter Larson. And Dr. Larson is an associate chair for the College of Education and the program chair for the school counseling program at Argosy University in Sarasota. She received her doctorate in Counselor Ed and Supervision in 2004 from the University of Florida. Earned her MA and EdS in school counseling, also from UF, and a BA in dance from the St. Leo College. Dr. Larson has more than 22 years of experience as an educator. She's been with Argosy University since 2007, and she's worked in Florida public school systems from 1994 to 2007, where she served as a school counselor and dance educator during those 13 years. Dr. Larson also has taught courses for the University of Florida and New College of Florida. I will be happy to facilitate and monitor today, and so if you have any questions for Dr. Larson, please put them in the chat area or the questions area, and otherwise I'd like to present Dr. Stephanie Larson.
Thank you. Okay, so today we're going to be talking about autism spectrum disorders and working with these kids in our schools. And the way I'd like to start today is just talking a little bit about the disorder itself. And knowing what we know about students with autism spectrum disorders, we know that autism, they're always unique, totally interesting, and sometimes mysterious. And I like to always begin my presentations when I'm talking about this topic explaining that each and every one of these children are different. And because of that, there is no cookbook remedy that we can apply to any one specific ASD child and have that particular treatment or that particular intervention work for them. And so it's very difficult, especially in an hour-long format, to give you a whole bunch of concrete strategies that you can use, because what might work for one kid is not going to work for the other. So I'm going to spend the time today talking about how we view autism and learning to understand what this disorder is about. And then I'm going to talk about mainly resources that are available to you that you can access for free, and you can go on your own time and look at the different types of things that you can be implementing in your schools. Because of the vast amount of information that's out there, learning to work specifically with autism spectrum kids is really like full-day workshops, week-long workshops, things like that. So I think probably a lot of you know that the symbol for autism is this puzzle, the puzzle piece, and that's because the disorder itself is a puzzle and a bit of a mystery to us. But the fact that each and every one of these kids is different and unique makes how to work with autism spectrum a puzzle in and of itself. So what we do know is that it just appeared somewhere around 70 years ago. The first people to identify the disorder was Dr. Leo Kanner, and he began with the first criteria sets and started studying the disease. Right around the same time, Dr. Hans Asperger from Germany found a milder form, and that's what we know as Asperger's syndrome today, or what we here in America call Asperger's syndrome. So what is in this name? What is in this autism spectrum name, and where did it come from? It first showed up in our diagnosis manual that, in the DSM-3 in 1980 as infantile autism. And in '87, it was amended, and it was called autistic disorder. In the DSM-4, we added this category called the pervasive developmental disorders. And in that category, that umbrella category, there's 5 different subtypes: autistic disorder, Asperger's disorder, pervasive developmental disorder, not otherwise specified, Rett syndrome, and childhood disintegrative disorder. These 2 are extremely rare, Rett's and CDD. It's very, very rare, and I'm not going to really spend any time talking about that today because we're not going to see this so much in our autism spectrum classification when we're thinking about IDEA. This would probably fall more into your other health impaired. So I'm going to spend more time specifically talking about those 3 types. So again, going to the DSM, right now the way it's categorized, it's in this pervasive developmental disorder umbrella, otherwise known as Autism Spectrum Disorders. And PDD is really an American term. It comes from our DSM. Across the world, it's more known as Autism Spectrum Disorders. So under this umbrella, we have autism, we have Asperger's, PDD, Rett syndrome, and CDD. So again, focusing on these 3 today. Long way. All right, so what we do have to discuss is the fact that the DSM-5 is coming out here in a couple of months. It's due out May 2013, and there are proposed changes to how the disorder is going to be diagnosed. The most obvious is that they're getting rid of the 3, well actually all 5. These will not be part of the diagnosis anymore. They're looking at moving this into neurological medical conditions, whereas these 3 are going to be collapsed under a single name, which is called Autism Spectrum Disorders. So we won't be seeing new diagnoses coming out as Asperger's or autistic or PDD, but rather now the diagnosis will be ASD, an Autism Spectrum Disorder. And so by collapsing Asperger's, PDD, and autism under one, here are the proposed criteria sets. Jumping to the 3rd one, we have to see that there's some sort of symptoms that are present in early childhood. It may not fully manifest until later, but we need to see that there's some symptoms there early on. The diagnosis is really collapsed into 2 main criteria sets. 1, clinically significant deficits in social communication, and we're going to talk about that a lot today, what a social communication is and interaction. Manifest by marked deficits in nonverbal and verbal communication, lack of social reciprocity, failure to develop and maintain peer relationships that are appropriate to their developmental, their age and functioning level. And then number 2, restrictive, repetitive patterns of behavior, interest, activities, manifested by at least 2 of those following. So the stereotype motor and verbal behaviors, things like stimming, things like rocking, excessive adherence to routines, ritualized patterns of behavior, and fixated interests. And I'm sharing this just so that you can get an idea that the disorder is going to be classified differently now. Certainly in the schools we would never be making any diagnoses, but I think that everyone, particularly school counselors, we really need to know that this is about to happen because it's going to change how the diagnoses are being made and how we may be, in turn, dealing with it on the school level. Okay, so what does this ASD, the spectrum, what does it mean to be on a spectrum? And basically that just means that, coming back to this puzzle piece idea, that the disorder manifests itself in many, many different forms. Again, each and every child is unique, managing a grab bag of different symptoms. In the example here, one child may rarely speak at all and have difficulty learning to read and write, and yet another can be so high functioning that he's able to attend classes in a mainstream school and speak with the peers. Another may be so sensitive to the feel of fabric that the clothing has to have all the tags cut off or can't have any tags, and then other friends who are ASDs, well, may not have that type of sensory issue at all. So again, each and every one being different lends itself to this idea of that it's a puzzle. The media puts a lot of attention on this word severity. And when we're thinking about severity, for example, the media says something like Aspergers is a less severe form of autism, or that particular child, he has severe autism. And I don't like that term because if we were to make a comparison to, say, the flu, you can't have the severe flu or a less severe flu. Rather, your symptoms that are associated with the flu are more severe or less severe. So in my opinion, there's no such thing as having a severe disorder. So what I prefer is to look at what's considered low functioning or high functioning. And what we know about our ASD kids is here's that spectrum, and each child may fall anywhere on this spectrum. If you're thinking about this in terms of IQ levels, we know that the intellectually disabled kids have an IQ below 70, and the gifted kids have an IQ of 130 and above. Our Asperger's kids tend to be higher functioning, and they tend to have higher IQs. The autism and the PDD kids really are falling anywhere. It's difficult to even get on a classically autistic kid a true IQ. They do have some nonverbal tests that are out there, but since the disorder itself has such a impairment with social interactions and tests, IQ tests are given in a social type setting where you're one-on-one having to interact, it's hard to get a real idea of what their true IQ might be. So again, when we're thinking about that severe, that a kid is severely autistic, I just caution you with that word because the severity is really about the symptoms and not the disorder itself. The CDC reported that the majority of kids being identified as ASD do not have an intellectual disability, meaning that their IQ is less than or equal to 70. Okay, so bringing us back to this puzzle and this idea that everyone is unique, how do we look at it going forward? So they're individual and they're unique, however, they do have some common traits, some things we see along any point on that spectrum. And that one thing is that ability to communicate and relate to other people, that it is a social disorder. But it's not only a social disorder because it's pervasive. It affects every part of their life and their being. So it's a pervasive issue that has this social component, but it really stems into all of the different pieces of their life because that social component is affecting all of the neurological and the learning and the being able to take in information.
Dr. Carter, we have a question.
Another common trait.
We have a
Yeah.
question here. The question is, if a child is so low functioning that you can't get an accurate IQ score, how do you know what their IQ is? Is it possible
Right.
to be low functioning with a high IQ?
Yeah, and that's really my point. When we're seeing, you know, where we're reporting on IQs with autistic kids, you have to take that IQ with a grain of salt. We really don't know, particularly if that child is completely nonverbal. So many of our IQ tests are verbally based. And like I said, we do have nonverbal IQ tests, but again, it's in that setting where they're having to interact with somebody. So right now, the answer to that is, I don't know. We don't know. We really don't know where their true IQ is, particularly these kids. These kids are more verbal and will interact with you. Are we good? Dr. Sabella, I can keep going. Did you hear that?
Oh, yeah. Oh, very good. Keep going.
Oh, okay. Okay, so we were here and we were talking about the fact that common among the disorder is that it's associated with rigid routines, repetitive behaviors, obsessively arranging objects. I've had students who couldn't carry on with the rest of their work because their desk wasn't properly set up or their environment wasn't properly set up. And they can become very, very rigid if you have something that happens that's out of the ordinary within the day. They may have a lot of trouble with that. Another common trait is this limited ability to imagine. If you were to, I have a son that's 22 months now. If I were to hand my son a toy truck, a common, typically developing response would be that he would grab onto the truck and he would try to move it back and forth and use it in its function as a truck in the real world would. And he might roll it on the ground and vroom, 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 and make the sounds like a truck would make. An ASD kid won't necessarily do that. They may fixate on the object itself. They might flip it upside down. They might spin the wheels and really get into the actual mechanical workings of it and just kind of taking it apart, looking at it, rather than using it in its function. Another example might be the phone, where if you hand a child a phone, they pick up the phone and they imitate what they see and say, hello, hello, and pretend to have these conversations. An ASD child won't do that. They're not going to use it in its function, if that makes sense. So typically what we see in a typically developing child, a typically developing person, is that they become experts on people. As they're really, really young, they're going to start their development with their parents, a relationship development. And as they grow, that relationship and that bond builds and builds. And they expand on that, and so they become experts in relationships, experts on people, and being able to interact with people. An ASD kid is going to have a lot of trouble with that. They tend to be experts on things. We see very, very young children being able to stack blocks and make really, really high towers, or become experts in terms of knowing maps and where things are located, or being able to take apart a vacuum and put it back together. The same with technology and on into car engines and all these different types of things, of objects. So a typical developing child working with relationships, working with peers, interacting with other people in a social manner, ASD having trouble with that they're more interested in objects and with things. So I did talk about how in the DSM-5 we're collapsing it into one diagnosis called Autism Spectrum Disorders, or ASD. But I think it's worth mentioning that there is a difference between an autistic, or what I call classically autistic kid, and this tends to be the middle to the lower functioning students, and then the Aspergers, which tend to be higher functioning. So our classically autistic kids, early onset, typically they're going to have this diagnosis by the age of 3 or 4. And it's a much more profound social dysfunction. Lower functioning, classically autistic kids are going to have very difficult time establishing any kind of relationship with people at all. Their language and their communication is significantly impaired, many of them not even speaking. And it's very difficult to get them to look you even in your eyes. They have a low understanding of their own feelings, or at least being able to express what those feelings are, and they have a much more difficult time in a traditional learning environment. So their natural contact with people is significantly affected. And their repetitive motors and stereotype mannerisms are much more pronounced. And typically we refer to this as stimming. Another early sign is hand flapping. I'm not going to show this whole thing. Whoops, sorry, that's loud. Trying to turn it down. Sorry, that was really loud. I was trying to turn it down for you, but that gives you kind of an idea of that flapping. And there's lots of different ways that they can do this: rocking back and forth, swaying back and forth, hands flapping. Sometimes they'll move their fingers around in really fast ways. But essentially that repetitive motion is relaxing and calming, and in some way stimulating their sensory system so that they can cope with whatever's happening around them. Asperger's, on the other hand, there is a social isolation and eccentric behavior that's noticed, but we don't typically notice this until they're a little bit older and until they're actually in a school-type setting. So a lot of times we're not going to get a diagnosis of Asperger's until they're kindergarten, first, second grade, when they're really having to interact with their peers a whole lot more than they did when they were little. And these impairments are more on two-sided communication with their peers and with others. They are more verbal, but they have trouble communicating in a verbal manner. Their speech is grammatically correct, but they sometimes sound peculiar, and they will often inflections in the voice is very different. They don't pick up on things like sarcasm. So if I were to say something like, Dr. Larson, let's see, Dr. Larson ate the cookies? There's a certain understanding that that's a question, like, oh my gosh, I can't believe that she would have eaten and stole those cookies. They don't pick up on that voice inflection in those different levels that we have in normal speech patterns that a typical developing kid would pick up on. Colloquial expressions, things like there's many ways to skin a cat. An Asperger's kid would look at you and say, why in the world would you want to skin a cat? That would make no sense to them. So they're very concrete. They take things extremely literally. So that's something to be very mindful of when you're working with ASD kids. Asperger's kids tend to be very clumsy. Common, I can remember walking through the halls and seeing kids walking in the line, and then the line stops, and yet the Asperger kid is not with it and doesn't stop and smashes into the people in front of them in the line. Of course, that irritates the peers, and they turn around like, ugh, would you pay attention, that kind of a thing. Very clumsy. They even move with really broad, big, gross motor type movement. Either hyper, where they're overly sensitive to things like lights, sounds. A lot of the classrooms will have, you know, like the fluorescent lighting where they put off that hum, and typically you wouldn't hear or acknowledge that hum. But an ASD kid, that's all they hear. It becomes very prominent. And of course, hyposensitivity, where they're undersensitive to things. And really common with Asperger's is this circumscribed area of interest, this little professor, where they can tell you anything and everything about whatever their interest is, whether it's dinosaurs, cars, trains, French literature. I had one student that knew maps and could say to you, what city did you grow up in, and what block was that? Or say, what street did you live on? And then they would say, oh, that was in the such and such block next to such and such. So this really intense level of knowledge about one very specific thing. So the difference between autism and Asperger's, and remember that they're collapsing this diagnosis, so we won't really have these two different categories. You know, the new diagnosis is saying that there's going to be a clinically significant deficit with social communication. However, a classically autistic kid is going to have that significant delay in language, quite often not even speaking. Year 3 comes along and they still have little to no words. Year 4. So there is a delay in that language development, that initial articulation of language. Whereas Asperger's, typically you don't see that. Typically they are acquiring language, learning words in a normal pattern. It's not until later when they're having to interact with those words that it becomes a problem. An autistic kid is going to not want to socially interact. They would prefer to be by themselves. They're very rarely going to be playing with other kids, whereas an Asperger kid is going to desperately, desperately want to have friends, want to play with other people, but they go about it all wrong. And many times it comes across as being offensive to other kids. And other students don't want to interact with them. For autism, very aloof, withdrawn, even apathetic to the immediate family members, the mom and dad. And Asperger's, where they're in the opposite, very attached, very incredibly close to their immediate family members. And there are trends where we have seen students who had the diagnosis of classically autistic that had intensive interventions that are no longer presenting this way anymore, but are now presenting this way, which lends support to some of the treatment methods that are being delivered. So one of the easiest ways that I can show you a brief little glimpse into what an ASD student might experience is through this little video. And this actually is from a 1944 study about social interaction with people. And so I'm going to show you this quick little 30 or 40-second clip, and I just want you to take note of of what it is that you are seeing and what it is that you're experiencing. Okay? So let me make sure it's the beginning. Okay, so Dr. Sabella, if you can just ask the group, and I can't see their hands going up and I can't see their comments, but if you can just maybe do a quick poll, 1 or 2 word answers, what did people see there?
Yeah, if you can just go ahead in the chat area, not the questions area, but the chat area, go ahead and make your comments at this time.
And I can't see any of those comments, so if you can just read.
We'll give people just a few more seconds. There are none yet.
Oh, okay. And it's playing, Canton. You get anything?
Okay, there are no comments, so we'll just continue.
Okay.
Oh, wait, I'm sorry.
Yeah.
There, people are writing in the questions area. So one person says, not sure what I'm seeing. Looks like individual items, then forming as one. I have no idea, really.
Okay.
Another one says, someone trying to fit in.
Okay.
Someone else saying, a fight.
Okay.
Jennifer says, the way an Asperger's feels about socializing.
Okay.
Sarah says, not sure, repelling.
Okay. So repelling, socializing, trying to fit in. What most of those comments are dealing with is that you're trying to attach some sort of storyline or some sort of meaning and attach that to these inanimate objects of a circle, a little triangle, and a bigger triangle. And what most people do is that they attach some sort of story, and that maybe the one figure was a bully, and then the other were 2 friends, and the bully was picking on one, and then, you know, they kind of got into it, and they tried to protect, and that's a common reaction. And most typical developing people will look at that, and they do that. They assign some sort of social interaction story to that particular clip. And so in 2000, Dr. Kiln actually did a study with that very clip with both typical developing children and ASD kids. And you can see here a typical child's response, and this is just one sample. So what happened was that the larger triangle, which was like a bigger kid or a bully, and he had isolated himself from everything else until 2 new kids came along, and the little one was a bit more shy, scared, and the smaller triangle more like stood up for himself and protected the little one. The big triangle got jealous of them, came out, and started to pick on the smaller triangle. The little triangle got upset and said, like, what's up? Why are you doing this? Okay? So there again, attaching meaning, attaching emotions, attaching a social story to the clip. An ASD kid, the big triangle went into the rectangle. there were a small triangle and a circle. The big triangle went out. The shapes bounced off each other. The small circle went inside the rectangle, the big triangle. So you can see here the pattern, that it's more about the figures, the shapes, and that social interaction piece is lacking. Small triangle and circle went around each other a few times. They were kind of oscillating around each other, maybe because of the magnetic field. Notice that it's now talking about scientific-based things, object-based things, rather than relationships. After that, they go off screen. The big triangle turned like a star created and broke the rectangle. So maybe some sort of background knowledge with the Star of David. So you can see the difference there. And what that tells us is that typically our ASD students really just have a very, very difficult time picking up on social cues, that kids react with their peers so quickly, and that these social cues are flying out of the kids really, really fast, and that a kid with ASD is going to have a really hard time processing that and won't notice all of the different social cues. A very common one that you see is close talking. They'll get really close, and it makes the other kid feel really, really uncomfortable, and the kid will back up, and the ASD kid will then step forward again, and they don't understand that the child is backing up because they're too close. Okay, so moving on. Our newest, depending upon which country you're in, you're going to get different numbers. But I stuck with here in America. The CDC is noting now in 2012, 1 in 88 children are diagnosed with ASD. That's a dramatic 23% increase from the 2009 report, where it was 1 in 110. 78% increase since the 2007 report, whereas 1 in 150, and over a 600% increase in the last 60 years. I typically get questions at this point that are about, well, why is this happening, and why are we seeing this diagnosis more and more? And really, I think it's a combination of different things. Yes, we definitely know more about it, and so the diagnosticians, the pediatricians, the psychologists who work with this population know better and can notice the symptoms, and so they're diagnosing it more because they know more about it. But I think it's more than that. I think that it's just there's flat out more cases now, and we'll talk about that in just a moment. It is 5 times more likely, nearly 5 times more likely to strike boys than girls. It's the fastest growing serious developmental disability in the United States. There's no racial, ethnic, or social boundaries. It knows no income levels. It's not limited to poor children or children who come from really educated backgrounds. It does not know boundaries of lifestyle choices or educational levels. The newest stats, it does show that white children are more likely to have ASD than black or Hispanic. However, the Hispanic population is the the largest increase in diagnosis that we've seen from 2002 to 2008, following behind with the black children at 91%. Again, all of this information and these stats are coming out of the CDC in their report last year, and the way that they're getting this is through this Autism and Developmental Disabilities Monitoring Network, the ADDM network. And if you want to read more about that report, there's a link there, and I'll be sure to send out all of the resources after this to the participants.
Stephanie, we have a question, if I can interrupt. The question is, any link Any
Go
link
ahead.
between nutrition issues like use of corn syrup and so many food products like sodas?
Yes, we're gonna get there in just a minute because we're going to talk about some of the causes, which is coming up in another slide or two. When is ASD diagnosed? And we kind of touched on this already. Classic autism is usually reasonably diagnosed by age 3, but we're seeing it as early as 6 months. And again, Aspergers is not noticed until a little bit later when the child enters K through 12 school, usually around somewhere between kindergarten and 2nd grade. Parents are usually the first to notice these behaviors and that the children are just not reaching the appropriate milestones. Although some parents describe that it seems like their child was meeting some of the milestones and then lost those skills. And this is just a picture of a common report from parents where an ASD kid will take cans and stack them and stack them and stack them. So stacking is another common stemming type activity of ASD children. So what is causing it? And this goes back to the last question. And I think we all have followed to some extent the controversy that has been reported in the media surrounding vaccines. And I'm not going to spend a lot of time on this. But yes, there was a lot of controversy about the MMR, specifically the measles, mumps, rubella vaccination. And that came from a study by Andrew Wakefield. And essentially he was looking at 8 children who were autistic. And he published a study about these eight individuals and things that he found with those 8 individuals. People that were associated with that study, 10 of the 13 have withdrawn their claims about the original methodology that was used in that study. As a follow-up, the CDC, Center for Disease Control, American Academy of Pediatrics, and the World Health Organization state that there's just not enough evidence to support the contention that vaccines, and specifically it's thimerosal, which is a preservative that's put into vaccines, has caused children to develop autism. 6 studies have shown that the thimerosal is not linked to autism. Another 3 have shown that there's no link to neurological problems. Thimerosal was actually removed from vaccinations in 2001, and yet, as the previous slide showed, the rates have continued to rise. In 2009, the National Vaccine Injury Compensation Program, which is actually like vaccine court, ruled that the MMR did not cause or contribute to the cause of neurodevelopmental disorders such as ASD. So not getting into that controversy, we still have this firestorm that's swirling around where people are saying, what is causing this? And they're still trying to blame the vaccination. And I guess my easiest way to kind of describe this is that I can't see you all raise your hand, but I would ask you, raise your hand, how many of you remember growing up and having your parents not take you trick-or-treating to general public places, and that there was this fear that there was going to be some sort of poisons or razor blades or needles or something that was put into the Halloween candy. And so everybody feared this, and everybody, I can remember growing up that they would even, the hospitals would open up on Halloween where they would x-ray your candy. And I don't know if anybody's raising their hand if they remember that as well. But they actually did a study about that, and in 1988, I think it was, what they had found by this was that nobody had ever been harmed by a stranger's Halloween candy. and that the story actually came from a 5-year-old boy who had overdosed on his uncle's heroin. And the uncle, to cover his tracks, put heroin into the child's candy to say that he had picked up this candy from somebody and that's how he overdosed. And so the lesson from that is that once that information is out there, it's very, very hard to take that back because that fear has now been injected into the public. So that's one piece about why the accusations continue. The other piece is that parents are left at a loss, and there's just no specific definitive answer that's telling us where this is coming from. Now, the research is just exploding, and it's very, very difficult. It's a full-time job to keep up with the autism research. But what we do know is this. Number one, that there is definitely some sort of genetic factor. They've looked at the Genome Project where they're identifying a series between 10 to 12 different genes where they're having these hotspots that are coming up. And it's not one specific individual quote-unquote autism gene, but it's just we're seeing in this range of, I think, 10 to 20 genes that are playing a role in this, where it becomes a hotspot or it's producing some sort of abnormal protein. And so there's a lot of research right now that's looking into those genetic factors. There's things like having older parents. There's studies about where if the mother is over the age of 40, that there's a 50% chance that the child will have autism. And then something like with each age, so at 41, that 50% is gains 8% with each year. So it's a 58% chance at 41, so on and so forth. Then, of course, there's the environmental factors, and that's getting to what the last question was about. There's so many different studies that are happening with soils, with food, with our pharmacological medications and things like that. And yes, they're finding some correlations with certain drugs. They're finding some correlations with certain types of foods where we're seeing a greater risk with that child being born with autism. So yes, there are there's some evidence that some of that is linked. The problem is, and plastics is another one, we just don't know, and that right now it doesn't seem to be like one magic thing that we have found that we've said, aha, that's what's doing it. So, you know, genetics, something to do with mom's salt shaker coming together with dad's pepper shaker, and the two of them mixing together is producing something in that genetic makeup that makes the child susceptible to ASD, and then adding to that some other environmental cause that's interacting with the genes. Any questions there? That tends to ignite quite a few. So it leads us again to, again, we still don't know what it is. Back to this idea of the puzzle piece, and that it is a mystery right now. There is so much research that's happening every day about this topic, and so I suspect that we will get more definitive answers even within the next 10 years. All right, so treatments. No one thing, treatment method works for every single child affected with ASD. So therefore, there's no cure. There's no one treatment, such as a pill or such as even an alternative thing like changing a diet and then having it work for the entire ASD population. However, we are seeing that some children with certain treatments and certain interventions are becoming quote-unquote cured or virtually asymptomatic, where they had the symptoms, they had different ASD symptoms, and now through this treatment, those symptoms have disappeared and that they are appearing like a typical peer. What we do know is that the earlier that you intervene, the better the prognosis. So as soon as the child is diagnosed, that intervention should begin. Appropriate therapies need to be implemented for at least 2 years during those preschool years, and then we're seeing significant improvements. So this really is a big deal for us in the school for our pre-K population and our early intervention under IDEA law. Effective programs focus on the communication, the social, and the cognitive skills. The academic piece really becomes secondary. So these are the most commonly seen interventions. The empirically based one and the one that's gleaned the most, the best prognosis is from applied behavior analysis, or ABA. And there are certificates that people can get. There are actually standalone degrees where you can become an ABA therapist. And this is very intensive, many times one-on-one type therapeutic approach. In our cluster sites that have autism clusters, the teachers, the special ed teachers, the special ed aides will often be trained in these techniques. We're always going to partner speech and language therapy, social skills training, occupational and adaptive therapies. I guess I would add to that physical therapy as well, positive behavior intervention support, and of course medications for comorbid disorders. We do see a lot of comorbidity with things like ADHD, depression, anxiety. Those are 3 of the big ones. And then there's a lot of really, really interesting research with robots right now. If you ever have time, go to YouTube and type in robots and autism, and you can see some of those videos. It's really exciting. But as we've learned, it's this social interaction disorder. And so what they're doing is that they're teaching facial expressions and how to interact with robots. And we know that the ASD kid likes a thing. So this is a robot, which is a thing, but they're simulating emotions and social interaction. So a lot of really promising and exciting stuff that's happening with that. Alternative methods that we've seen, the sensory integration techniques and therapies. Of course, diets, which was somewhat mentioned before in the question before. I know that there's many ASD kids have problems with gastrointestinal problems, and so changing their diets to help the gastrointestinal problems have actually ended up, not intentionally, but quote-unquote curing some of these kids. And again, you can't call it a cure because what a change in a diet for one kid will really have virtually no effect whatsoever on this other ASD kid. Okay, so these are different alternative methods. These ones that have a star, there have been studies that have disputed that and shown that those are not effective. And then the chelation, we were talking about the mercury-based preservatives like thimerosal. Chelation is like a chamber where kids are inside of that chamber and it removes heavy metals. And there's actually, this has been dangerous for kids because it's pulled the good things, the good metals out of your blood, like iron. And I just glanced at my watch and I'm seeing that I'm getting close to the time, so I'm going to zip through this.
Stephanie, I just want to double check. I just let everybody know that this will be their last chance to ask any questions. So we have about 4 minutes left.
Okay.
In fact, we have one question just came in. If Jennifer asks, if a non-diagnosed ASD child is sent through a typical school with little to no resources for ASD or even acknowledged of the ASD, can they be successful? I'm thinking particularly Aspergers.
Without a diagnosis, it's going to be really, really hard. I'm trying to get to this particular slide. So in the 2004 revision to IDEA, autism was added to the list of quote-unquote labels. And so in order to provide that child with services, they actually have to have the IEP and the ESC label of autism. So you can do that with a couple of different ways. You can get diagnosis from a physician, or if you want to go through the evaluation, you can. Finding an appropriate evaluation is tough in some of the smaller, more rural districts. A lot of psychologists use the GARs. I think it's better if you can just get the diagnosis from the physician and then start. You don't have to take these. In my opinion, you do not need to take these kids through RTI. If you have that physician's diagnosis, you should be working on the staffing placement so that you can develop an IEP, and you can. Our higher functioning Asperger kids can be in the general mainstream with support from their IEP. So I did want to get to, here's some IEP guidelines that are really helpful, and I'm going to send these out to you. But what I did want to get to was this. On autismspeaks.org, they have this really great school community toolkit. And in here is where I think is the most succinct and well put together resource for teachers, for administrators, for counselors to go through and look at. Just to show you in the appendices, this is particularly good strategies to use in the classroom and when you're working in groups or one-on-one with an ASD kid. So I highly recommend that you can go in here, download. I mean, it's a huge toolkit for you, a couple different manuals that you can access through there. These different sites, and then this one, again, that's another really big manual that you can download, and they have concrete examples of how you can intervene and how you can create interventions for your ASD population. Any other questions?
All right. Well, I don't see any other questions. I want to thank Dr. Stephanie Larson Carter for a very informative and resourceful presentation here. We have recorded this, and if you have registered for this webinar, you'll receive a link as soon as it's available. Thank you again, Dr. Stephanie Larson Carter.
Yeah, thank you very much, and I'll send out all of these resources that folks can go and access.